Thanks, Jim. All right, we're going to talk a little bit about intake models. And this is an area that's intense, I think, right now for innovation and research. And so I'll tell you about some of the stuff that's in the literature and also talk to you about some of the things that we uncovered with a grant that we got from AHRQ looking at this. Little background information, then we'll talk about the case for why it is important, then talk about some of the new models and some of the technologies that's being applied to support the models, because I think it's kind of cool. So you heard this morning. Visits keep going up, the beds have gone down. The nursing staff, not only are we short nurses, but they're of a different caliber. And I have to tell you this little story because I think it may be what we're in for. Remember we said this morning we talked about Ashley, the nurse that can't make a nitroglycerin drip? Well, I was working in the ER, and you know, sometimes it's busy before you sort of register what's going on. I kept seeing patients wheel by to go to x-ray with like 10 cotton balls taped to their arms, okay? And I'm just still sort of not registering this or putting this together. But we also had 2 male nursing students, young men, and the sad truth was they were a month away from graduation, so a month later they were probably working their mischief in your ER. And then, do I dare tell you this, in Utah, the nursing programs make the males wear, it's a darn dress, for gosh sakes, with slacks. So I had frickin' frack working in the ER, and the cotton balls going by, and I'm still not sure of not getting it. Well, I had seen a very cute, sweet little old lady with one of those nasty proximal humerus fractures, you know, and I said to her nurse, Jill, just get a line in, give her something for pain, and then get her to x-ray as quick as you can. Well, it's like 45 minutes, an hour, I'm still waiting, where's the x-ray? And I go, and I was hearing kind of whimpering, frickin' frack, have about 8 cotton balls on her good arm, and now they're pulling on the bad arm and saying, honey, we just need to get this IV in. And I literally, I felt like I was close to fisticuffs. But what I'm saying to you is I believe it's a new game out there, that the inexperience of the nurses may even be dangerous to your patients. And that's another reason why I want you to get in there quick. I want that doctor-patient encounter to take place as quick as lightning, for the sake of the patients. And as we said, we're the front door, and they're sicker. Now, a few more reasons why we care about this. So I like the word, Rick makes fun of overcrowding. I like overcapacity. Great slide, don't you think? The idea that you have more patients than spaces for them. And overcapacity meaning you have more x-ray orders than the ability to take them, more labs to process than the ability to do them. 80% of hospitals spend part of every day now over capacity. Anybody here not got that? Anybody always got a bed open? If so, I want to know where you are, because if I have a kidney stone or something, I'm coming to your place. But isn't this the way we live and breathe? Evening shift, over capacity every day. And we're not usually liking it this way either. The very best ERs are looking at cycle time measurements, looking and getting more and more granular on the data. And when we talk about successful QI projects tomorrow, I'll go into the methodology and how this deep dive on the data can really help you fine-tune your department. And so we're getting very, very focused on it, and door-to-doc is one of those sub-cycle times that we're paying a lot of attention to. I talked to you about how NQF has identified these 2, their cousin measures, as things they're going to pay for. And I told you I was going to tell you. Now, mind you, this was as of early summer, the model that is being considered in terms of the payment scheme. So value-based purchase of healthcare. CMS is going to take 2 to 5% of DRG money on Medicare patients and withhold it, okay? Then 70% of your score will be based on those quality measures that we talked about. Remember, they set 10 up to CMS, 2 of them being the door-to-doc and left that being seen. And an additional 30% will be on patient satisfaction scores. And again, the details haven't worked out, but trust me, you're going to be paying attention to this. And we have a talk tomorrow all about patient satisfaction and the things you can do to get the most bang for the buck in your department, since this is the game we're playing. And then you have the ability, based on how you score on these performance measures, to earn back the money that they took. And so you will notice that at 90% you'll get everything back. If your performance is at the 90th percentile for ERs, you have a chance to get that 5% back, or however much they've taken. No opportunity to game it and get more, but you're just trying to keep, I mean, I'm frustrated by this, and I'm not telling you in any way, I don't want you to just think that I endorse this. I'm just telling you this is as I know the plan so far. And I wish Brent was here because he might have heard something different because he's served on some of these task forces as well. Sir?
I just think people are going to fudge the numbers to get the payment.
Well, yeah, and it's going to be, the devil will be in the details, like I said. Now, wouldn't we all consider opening up a new patient satisfaction company like Presgany where we could guarantee you good scores? You know, I mean, think about the opportunity for gaming the system. So I'm very interested to see how they're going to implement it. Yeah, do I think there's ways to cheat? Probably, you know. And then my numbers look very analogous to Rick's. You know, I made some assumptions too. $300 for a discharged patient, $7,000 if they're admitted. Looking at average left without being seen rates for the country, which are 3%. Looking at average ER visits and walkaways based on that. And you're losing close to $1 million a year at your one shop if you're average, just with people walking down the street. Other reasons why this little time interval, like you do understand this. So you can have patients that are seen and it takes 4 hours. If they see the doctor in a short period of time, they will rate the experience much more positively than if they wait an hour. And you know what's the sort of time that people will give you? It's the same amount of time that people will wait for a table in a restaurant, by the way. Anybody know? How long do people wait before they start to leave and get angry? They'll wait 30 minutes to see your mug. You got 30 minutes to get in there. And that's been pretty much reproduced in a number of settings. So it correlates with better patient satisfaction, lower walkaways, and improved throughput, actually. And it may be because you're getting the guy who's important to the patient to start that workup. We talked about these 3 cases. I just want to make sure that you're familiar with them because I think you should know this as part of your specialty and industry. Did everyone see this? Who did not see this video? It's a psych ER, okay, in New York. But it may be a psychiatric ER, but we are tarred with the same brush, if you will. And when you see the live video, there's a security guard who wheels himself backwards like this, looks at the lady on the floor, and then wheels back to his television and does nothing. And that was just played over and over. And it was a woman who had died on the waiting room floor. But the story is, you know, death in a waiting room. Oh wait, let me show you the other 2. And then this Vista Medical Center case was a woman came in, presented with chest pain, was sent back to the waiting room. When they went to get her 2 hours later, she was dead in the chair. And the coroner made it a homicide case. Did you all know that was afoot? I mean, this is huge because we have not seen that before. I mean, there's one thing to worry about medical malpractice, another thing to be worried about something becoming a homicide case in your department. And then the last one was an LA County case where a woman was in the ER, and I hate to say it, but it was really hard to not laugh when you heard the audio tape because it's kind of humorous. She's in their ER calling 911 to come take her someplace else and trying to convince them to come and get her and take her. And actually the poor woman had perforated bowel and died. And so our reputation has been soiled a little bit by these cases, and they were really rapid fire, like right in a row, and the meter's running with it. And I want to reiterate what I think I hear from the community, and I think Jim alluded to this. We are still the white hats in our communities. Our communities still think of the ER as, you know, we're trying to do a tough job with minimal resources, and they're behind us, you know. They still support us. But I think in terms of this, bad stuff happening with people in the waiting room, they just want it fixed. And you should be getting that message loud and clear. They want this fixed, and I think there's less and less tolerance for this. So these are more points for why we really care about this particular issue. So there's a lot of sort of new processes afoot. Some have made it to the literature, some not. And I'm going to tell you about them. But let's start where we are. This is typical triage in 2009. I've been in so many ERs, and this is more or less it. Whether you can see it or not, let me just point to this. All these steps happen before the doctor sees the patient. And these are things like name gets entered, goes back to the waiting room, there's initial assessment. If they look very sick, they get put in a bed, most cases, back to the waiting room. Registration calls the patient's thinking, oh yeah, now I'm getting somewhere. They get registered, back to the waiting room again. I'm seeing most ERs that have a couple, 3 trips back to the waiting room. How much value is in this for the point of view of the patient? You know, they came to see the physician. What's all this stuff in between? This does not matter. The other thing that I see, and tell me if you don't often experience this, you're free. You could see that patient. But they got to go through this lengthy triage tradition, if you will, and ritual, and that's in between you seeing the patient. I made the case in my ER, because remember, we always say at IHI, data and a story. So I'm not busy, and I can see through the glass an elderly man who's sitting there, and it's 25 minutes has gone by. They don't bring him back. I'm like, Jill, I can see him. And she said, we're going as fast as we can. And I know that feeling. I mean, sometimes it's stressful for the nurses, sometimes it's stressful for the docs, eh? We're not always quite jiving. And so I waited another few minutes, and he's just looking like he doesn't feel good. And she said, look, he's foot pain, no injury. And she's still trying to get caught up, feeling very stressed and so forth. So I run out to the waiting room, and I do the unthinkable. Anybody get in trouble at their place for going into the waiting room? Yeah, it's my favorite trick. I take off his shoe and sock. What do you think I see? Black foot, black, cold, pulseless foot, avascular foot. And so I use that story, though, to make my case. They shouldn't wait, and especially if I've got room and I'm free, pull them back, pull them back. And so that's what this whole pull to full model is being encouraged on that basis. So most places have this many steps, no value in it from the point of view of the patient, lengthy, redundant, not a good process. If you're going to do a sort of traditional triage, I showed this morning in the design course, you got to make sure that you staffed it up. And I still would like to see you shrink it back to a 6-minute process like the Mary Washington way. And remember the curve, which may mean triple triage on the evenings. And anybody float somebody to triage back and forth and flex up and down? That's the other thing, is designing processes that flex with the demand capacity management. Not having it run the same way at all times, no matter who shows up and how many. So it made sense 20 years ago. 20 years ago, I never even thought about this. When I was working in an ER that saw 18,000 visits a year. So you're going to bring them back a couple an hour. You're never going to get too backed up, are you? Even if you make your triage very lengthy and take 20 minutes with it. But now we're much busier. And on evening shifts, sometimes it's like a darn mass casualty scene. The Christiana Care talks about how they will sometimes get 60 patients in an hour. Now, how do you contend with that? And remember, we control it all, so we should be doing something different. So putting a mid-level provider, there's several studies now that show that that's expeditious. Like I said, I still prefer the physician. And let me just, as I go through these studies, let me refer you to one article. Anyone see, I believe it came out last month, the Weiler article. It's a review in Annals, and it's called Review of Front-End Processes, I think that's the name. Jennifer Weiler, who was at St. Louis and is now in Denver, she actually just reviewed in a very thoughtful and systematic way every piece of literature she could on intake models. The trouble is, by the time most of the stuff makes it to the literature, many of us consider old news. We're looking for that other cutting edge stuff. But still, it's a nice summary for you of some of the different models that people are trying. Anyway, the triad study, and I just love all the initials, because it's like alphabet soup with all these new intake models. Triage, rapid initial assessment by a doctor. These are basically doctor and triage deals, and it's has a great positive effect on length of stay, patient satisfaction, even staff satisfaction. So there's a number of advantages and a lot of cases now that have been written up that attest to this. A third of patients are going home from there or more. And that's why I like it, because it's offloading the ER in a way. Before they get naked and get in the back, you're seeing them when they're eating potato chips, saying their stomach hurts. You get that virgin assessment, and you get to act on it, and maybe they don't even need to come back. But this was another one that's surprising. So St. Joseph of Orange, I love California. You guys, you're working like in an amazing environment, I think, now with all of the legislations and the ratios and so forth. I mean, it's really sink or swim, and some people come up with some very innovative things. And remember, we're always talking about HIPAA and privacy. What they did was they had a little team, and when every room was full and people were waiting, they went out in the waiting room and they said, Mrs. Smith, we know this isn't private, but we wondered if you wanted to talk to us about what's wrong with you, so maybe we could start some tests. But if you want to wait for privacy in a room, we can do that. What do you think the patients say? They're yapping on. They'll talk about their vaginal discharge or anything in the waiting room. I mean, they're like, yeah, let's talk, doc. It's amazing to me. No privacy. We would think this is a horrible thing. And this was a huge patient satisfaction boost. 96% rated their care good to excellent when a team came to them in the waiting room with everybody around and started their workup. So maybe our expectations are not often the patient's expectations. So that was the RADIT study. Then Tom Mayer, he was probably the first one and an early member of our Emergency Department Benchmarking Alliance at Fairfax and Nova, very busy ER, that started looking at, they call it team triage, which is basically a team going, they had a little intake area and a team would descend on the patients. He never published it that I know of, but he was one of the first people that noticed, hey, I can get pain medicine quicker, patient satisfaction goes up, 34% of them can go home from there. And then Ted Chan and Jim Killeen, these guys are really innovators and really computer geeky guys. They're one of the first places that wrote up barcoding lab specimens from the ER. How many of you barcode your lab specimens? I mean, I think they were the first ones to write it up. So anyway, they did the REACT study, and it's basically a no triage. Just pull them back and start work, a lot of it protocol driven. But if you're gonna do the triage, then I wanna encourage you to do it very limited. An alternative to it is what Jody Crane does is he does a pivot nurse first. The pivot nurse is a very coveted job. She is a highly trained, highly experienced, no new grads, and her job is to literally call which track they go to. And if you remember I talked about Mary Washington, they have literally 3 tracks, but they're mirrored. So they have 6 treatment zones, if you will, to send patients to. And they were in a lot of trouble. They had this big new ER, 100,000 visits a year. Could you imagine how many of you could weather 14 letters to the editor in your local paper? I mean, this was not good PR. 5-hour length of stay, lots of complaints, 1/3 of the staff quit. And so they did this thing where a pivot nurse would see them, send them to one of the 6 teams, and they are seen almost immediately by the team who does both triage and an initial assessment and starts their workup. Some can go back to the waiting room, some go to the main ER, some go home. So, and they, with their new methodology, they can see at least 20 patients an hour, they say. And their abbreviated triage, yeah. Oh, it's a pretty complicated model. They have, get this, and I think it's brilliant, a doc, a PA, a nurse, and a tech, plus a HUC, okay? And so I think the HUCs may share. The HUC might have 2 teams at once, all right? So, and how they do it is the doctor sees with his team, if the patient's gonna go to the waiting room, then the nurse will follow them up. If the patient's gonna go to the back and be a more complicated workup, then the PA follows it up. But in the end, what I love about it is these different streams, those 2 push the data to the physician. So imagine it being, Dr. Johnson, everything's back, that lady doesn't have pancreatitis, and everybody knows what the diagnosis, the differential was because the team was there at the start. Everything's back, it's not, it doesn't look like it's pancreatitis, do you want to do anything else? They push the data to the physician, they chase the data for him, and I just love the model. And they seem very happy with it too. Yeah?
So how do they model their team based on volume? Because obviously, if you have 60 patients coming in an hour, that team's not going to be able to see everybody. It takes some time, right? I mean, there is some.
Yeah, but if you've got the greeter nurse at least getting people into a stream, that breaks it down, right? Dividing it up somewhat. And then you've got a team that's moving back and forth. And I'm sure it flexes somewhat. Like I could see how the physician may leave the nurse to do some stuff and run with the PA to see the next patient. Sure. You know, could you see it kind of flexing back and forth? But the idea being that when possible, a team's going in there and doing the initial rapid, both the old triage as we think of it and beginning the treatment, you know, and it may be go to the waiting room and wait for your x-ray or wait for your labs, or it may be you better come to the back with us, you're sick. So, and mind you, the sick ones in the back are handed off to a different physician. But remember, this is a 100,000 volume place, so they're going to have that kind of staffing. If you are 30,000, you won't have that, so that model may not work for you, at least not in mirrored images the way they do it. And anyway, they brought their length of stay down, patient satisfaction up, walkaways down. It was hugely positive. And they used this concept we talked about this morning about a diagnostic waiting room. They're not all occupying beds. Diagnostic waiting room. Let me tell you about this. So in the interest of this sort of stuff, Intermountain Healthcare, the Institute for Healthcare Delivery Research, and EDBA, which we've talked a lot about, we applied for a grant from AHRQ to study for a year's time new intake models. And the first half of the grant involved soliciting new stuff around the country that's being done. So we solicited that from every organization that we could to see what kind of new stuff is being trialed. We vetted those. They're going to present at a summit in which we've invited people from CMS, Joint Commission, policymakers in the government, and so forth, to come to Salt Lake City and attend this summit where we're going to flesh out some white papers and policy position papers on intake and what's sort of the best process, what's new, and so forth. Part of it is an attempt to look at and move our specialty forward in the area of intake, because as Jim said, we don't even have a journal of ED operations. We don't even have a journal of ED operations. And then the other thing is to start to educate the policymakers and government people as to what this is about in the trenches, because I think in many cases they don't know. They don't quite get it. So the submissions that we got fell into three categories. People were changing the physical plant, they were using technology in a different way, or just changing the processes. And the physical plant changes, I talked about, who didn't hear about Arrowhead Memorial this morning? Is it a sizable number? Okay, a few people. I'm going to go very quickly through it then. So this year, their census almost doubled in 5 years. Look how badly it was going based on their metrics. 20% of patients leaving without being seen. Door-to-doc times of 4 hours. I think a lot bad could happen in that 4 hours. So they decided we're going to have the physician or mid-level see the patients first and put patients into one of these buckets. And 50% of their crowd went home. They did it without even remodeling. They brought in these cubicles which don't even require a building permit. They're considered furniture in California. So they brought in cubicles on the weekend, converted a big old room that used to be, I think it was like part of a registration or something, some filing room or something, turned it into this. Here's another view. And these are their intake cubicles, and the physician sees the patient really quickly. And look at this success story. Their door-to-doc time down to 31 minutes in 2008. Their left without being seen rate under 1%. So it's a huge success story. Now, Methodist Sacramento, they are underbedded by the numbers I gave you this morning for how you can kind of calculate where your bed should be. They see 42,000 patients and only 15 beds. But they did something really bold, and it's a very different model. They said, we're giving 6 beds over to triage pods. And they've staffed it a little bit different too, but you know what, it's interesting because Brent James thinks that with the physician shortage that's looming, that more and more medicine is going to be practiced like this, in sort of a pyramid. So you have a doc, 2 PAs, 4 nurses, and then the nurses have techs, and they are roving back and forth in this 6-bed space. Nobody can stay more than 15 minutes. 15 minutes, you've got to call it one way or the other. They go to the waiting room, they go home, or they go in the back. And so they're doing this, and their left without being seen, which was 5% above the national average, is now at 1%. And it's been hugely successful. Who would be scared to do this? Give up 6 of your precious 15 beds to an intake area. But this triage pods thing has worked very well for them. Carolina's Medical Center, anybody that's vertical when they come can stay vertical for the most part, and they're doing intake in Barcalounger chairs. They're doing something else kind of innovative that I'll show you. Improved door-to-doc, decreased left without being seen, decreased length of stay, and it offloaded the main ER, because if they come in walk-in, they got to prove that they can't stay vertical and walk-in. That's their approach. Different approach, which now they come in walk-in, we get them naked and put them in a bed. So this is a different approach. And then how can technology help us? Oops, here we go. So Chan and Killeen at USD again, always doing something innovative. So they have what they call a self-populating medical record, where the data that's there in the hospital record from other places is automatically crossed over to your intake paperwork. So you have less documentation that has to take place in that intake. It's just automatically populating those fields. So I think this is very clever, and I suspect this is the way that technology will help us in the future. Does it make sense? So in other words, you don't have to query the same questions over and over. If the medications and allergies and so forth are already there, it populates the sheet. You said, patient, everything right here? And you're done. It's much quicker. Then Medical College of Georgia, they are in the middle of apparently 5 nursing homes. And every day, just around 5 o'clock, anybody have this? The ambulances come and bring all these patients to the ER, right? The geriatric swoon, so, you know. So if they were worried about this, so they piloted something new. They have a telemedicine setup where the physician can talk to the staff at the nursing home and hear and look at the patient. And they are decreasing the number of patients being transported. Very often, they have something simple that can be managed from the nursing home. On the other hand, if the guy's drooling and his eyes are deviated to the right, they can say, come lights and sirens, and I'll activate the stroke team. This is beautiful, don't you think? I mean, I don't believe we've totally, adapted technology to help us with this. Then Jim talked about the smart cards. Actually, in Ontario, they're already using this for intake. They swipe their card, and get this, the computer takes the history. So in this study that was recently published, it took 5 minutes and 32 seconds for first-time users to get triaged, if you will. Many said they were more comfortable talking to the computer than talking to a person about their bowel habits and whatnot, okay? It outperformed a physician in terms of abdominal pain history. Like if you think of the things that you'd like to have in abdominal pain history, the computer outperformed us for abdominal pain. It was very focused, and 92% would use it again. Anybody threatened by this? Hey, bring it on. Bring me all that information, and all I got to do is touch the belly and add that to my database, you know, my mental database about that patient. So this is kind of a new application, and I think it's where we're going to be going. Oh, sorry. This looks double. Okay, this is Carolina's Medical Center. And we talked about one of the things that seems to be important to us is having some kind of identification on a patient, right? So they're using bioidentification, kind of like that clear thing in the airport. They look at your retina. So they Palmer scan. It takes 15 seconds, and it creates a unique pattern that then they tie to a medical record. This takes 15 seconds. That's who they are. You can attach the demographic data later on. 15 seconds, now the doctor can see them. And one thing that they hadn't counted on that's been just a lovely thing is, you know, all of your intoxicated drunks with no ID on a Saturday night that at the end of the year have 6 different identification numbers? Now they can match them up. They match them. And as long as you have a limb that you can use your foot, so unless you're a quadruple amputee, this can work for you, and it's hugely efficient. I just love this technology. So they're measuring their door-to-doc time in seconds. It's like 45 seconds with this new process. All right, now just new process changes. Does everyone think of that? Do you look at that and say 1,500 bed minutes, give or take? 1,500 bed minutes. How are you going to use the bed minutes? And I want to suggest to you, you want to treat septic shock, you want to treat acute MI, you want to treat patients who are sick, you want to assess them. You don't want people hanging out eating Fritos on that bed. You absolutely do not. So it's not a park bench, and you should be very stingy with how you spend your bed minutes. And that's sort of a new model. At Banner Health, and they did this at 8 sites, of course anything that can be rolled out in different sized ERs is kind of interesting to me. And they called it door-to-doc split patient flow. And what happens, quick look by an MD and a nurse, and then you went to one of those streams. So we're seeing this patient segmentation thing we talked about, and real quick look into a stream, and what they found is that they improved their door-to-doc time on all 8 of these sites that they tried it on. All right, MGH, they call it the START program, supplemental triage and rapid treatment. And they're again using a greeter nurse, less than 2 minutes, and but they're being kind of bold about this. If they deem you non-acute, you go into a track that's not acute and kind of like a clinic. If you're acute, you come back and they dedicate all the resources to you. If they think you're sick enough and you get a bed, everything happens very efficiently. If it's abdominal pain for a year and you're eating Fritos, no fever, no vomiting, you're probably going to sit in the waiting room and be treated like you're in a clinic. So it cut their left without being seen by 50%. And then Ellen Weber, who's at UCSF, she went to Sheffield, England for a year and observed what they were doing. And as we talked about, they had a 4-hour time limit and felt pressure to get their patients in much more quickly. And so they're doing the same thing. Quick look by the nurse, no vital signs taken on every patient. If you're a young, healthy person with an ankle sprain, they do not take your vital signs. Horrors, right? In this country, we've never done that. Is it an idea? I think so. So young, healthy person with no reason to have vital signs checked, they're not checking them. And then they're doing the same thing. You're non-acute, you go through a clinic-like process, you're way sick, way bad, we bring you back. Because we don't have enough resources to get everybody through our system in 4 hours unless we start to parse it a little bit. Would anyone like this? I kind of like this. I do not want to turn anybody away, but I think that we can maybe change our speed and stream patients a little more appropriately. Maybe they all can't have that bed and have that model that we used to use. It's just not feasible. And then this is one of my favorites, Thomas Jefferson, low flow, high flow. Did I mention this morning in the design course a little bit? Okay, so just briefly, they change their intake model depending on who's at the door. So early in the day, when they're open beds, pull them back, pull till full. They huddle, and as soon as they're getting overwhelmed, then the doctor and nurse will huddle and say, we're going to high flow. And in the high flow model, they actually have an area that the team comes out and assesses the patient and decides, goes in the back, waits in the waiting room, goes home. So they're changing it. Anybody doing anything that sophisticated, where you're literally changing your entire process based on how many are coming and who's at the door? I mean, I think it's a great, and they had great data to support this new model. So the point is, as you think about your intake processes, that has to go. Everybody remember that? This is like from the early 80s. That's got to go, and there are very many new things I would like you to at least entertain bringing to your shop and changing. Any questions or comments?